Assalamu alaikum. I am Dr. Asma Hosna, Associate Professor, Department of Pathology, Bashundhara Ad-din Medical College. Dear students, welcome to you all today's pathology session. In our previous lecture, we already discussed about the disease of the ovary and also discuss details about the serous tumor of the ovary. Today, I am going to discuss about the mucinous tumor of ovary. So, the mucinous tumors account for about 20% to 25% of all ovarian neoplasm. They occur principally in middle adult life and are rare before puberty and after menopause. These mucinous tumors are classified into three categories, that is benign, borderline and malignant. When it is benign tumor, it is known as mucinous cyst adenoma, and when it is malignant tumor, it is known as mucinous cyst adenocarcinoma. And the vast majority are benign or borderline tumor. The primary ovarian mucinous carcinomas are uncommon and they account for approximately 3% of all of ovarian cancer. How can we differentiate between the mucinous tumor from the serous tumor? And the mucinous tumor that differ from the serous tumor in several ways. In case of mucinous tumor, the surface of the ovary is rarely involved and only 5% of primary mucinous cyst adenomas and mucinous carcinomas are bilateral. But in serous tumor, most of the patients are clinically present bilaterally. That means both ovaries are involved commonly in case of serous tumor, but in case of mucinous tumor, only 5% of the primary mucinous cyst adenoma and the mucinous carcinoma are bilateral. And grossly, the mucinous tumor are produce a large cystic mass, and some have been recorded the weight is more than 25 kg. And in cut section, we will observe that the cysts are multiloculated and the tumor are filled with sticky gelatinous fluid that are rich in glycoprotein. In microscopic examination, the benign mucinous tumor are characterized by the lining of tall columnar epithelial cell with apical mucin and that lack cilia. But in case of serous tumor, we will see there are presence of ciliated columnar epithelium, and the vast majority demonstrate gastric or intestinal type of differentiation in case of mucinous tumor. In mucinous borderline tumor, there are presence of epithelial stratification, tufting and or papillary intraglandular growth that producing an appearance striking similar to tubular adenomas or villous adenomas of the intestine. And in mucinous carcinoma, that are characteristically demonstrated by glandular growth that is now recognized as a form of expansile invasion. And the mucinous carcinoma that have spread beyond the ovary are usually fatal, but as stated earlier, these tumors are uncommon and must be distinguished from metastatic mucinous adenocarcinoma. This is all about mucinous tumor of the ovary. Then come to our next topics, that is the germ cell tumor of the ovary. About 15 to 20% of all ovarian tumor are germ cell tumor, and they are classified in the following category, that is teratoma, yolk sac tumor, dysgerminoma, choriocarcinoma, embryonal carcinoma, and polyembryoma. Now, what is teratoma? Teratoma arises from the tutti potential cell and can differentiate into more than one germ cell layer, and the age incidence is younger age or reproductive life. The teratoma can be classified into three groups, that is mature teratoma, immature teratoma, and monodermal or specialized teratoma. The mature teratoma are the benign teratoma, the immature teratoma are the malignant teratoma. In case of male, when it is occur in the testis, the teratoma is solid, and in female, when it is occur in the ovary, it is mostly cystic in nature. Now come to details about the dermoid cyst, and this dermoid cyst also called mature cystic teratoma or mature teratoma. The dermoid cyst, it may be bilateral in 10 to 15% of the cases, and the size is about 5 to 15 centimeter in diameter. The another name of mature cystic teratoma is dermoid cyst, and clinically it is named as dermoid cyst as it contains dermal elements. Basically, it is a benign cystic teratoma. During gross examination, the cyst is a unilocular cyst, and the cut section of the cyst shows cheesy sebaceous material and also presence of hair tuft, bone and cartilage. During the microscopic examination, the cyst wall is lined by stratified squamous epithelium and also presence of skin appendages, that means sebaceous gland, hair follicle. In the wall of the dermoid cyst, other material can be found that arising from all germ layer, and they are skeletal muscles, smooth muscles, brain, neural tissue, cartilage, bone and bronchial lining epithelium, and also present intestinal lining epithelium or gland, thyroid gland and bronchial gland. 99% of the cases of the dermoid cyst are benign in nature. Only 1% of the cases dermoid cyst may undergo malignant transformation. If there are malignant transformation, there are presence of squamous epithelial component, and so we will see commonly squamous cell carcinoma, adenocarcinoma or thyroid cancer. Now, what about the immature teratoma or malignant teratoma? Grossly, the malignant teratoma is present with a bulky tumor with smooth external surface, and the cut surface shows presence of hair, sebaceous material, cartilage, bone with area of hemorrhage and necrosis. And during the microscopic examination, there are presence of immature neuroepithelium, immature cartilage, bone, muscle and other tissue. Now, the monodermal or specialized teratoma, it may be stroma ovary or carcinoid. When the tumor must contain thyroid gland, it is called stroma ovary, and the complications are thyrotoxicosis, thyroid cancer and when there is a presence of neuroendocrine cell, that is called carcinoid. That's all about today's lecture, my dear student. See you again in our next class. Till then, Allah Hafiz.